Thank you for joining us for this session of CAEP's National Grand Rounds. My name is Amanda Collier, and I'm an emergency physician at Queen's University Kingston Health Science Center, and I'm the current chair of the CAEP Global Emergency Medicine Committee. Today's rounds are focused on developing emergency medicine in low resource settings, and we're delighted to be able to host Dr. Priyanka Railan from WHO's Global Emergency and Trauma Care Initiative. Also joining me are Dr. Megan Landis and Dr. Kirsten Johnson. Dr. Landis will be moderating and will be helping to take the audience questions during the talk. Dr. Landis is an associate professor and clinician investigator in the Department of Family and Community Medicine, Divisions of Emergency Medicine at University of Toronto, and an attending staff doctor in the emergency department at UHN at the University of Toronto's largest downtown teaching hospital. Her research interests include the delivery, growth, and expansion of emergency medicine services in low resource settings, prevention of mother-to-child transmission of HIV in sub-Saharan Africa. She specializes in operational research that leads to change in clinical practice, and over the last decade has worked clinically and led research in Lesotho, Malawi, and Ethiopia in both emergency medicine and HIV services. She's a founding member and current director of Global Health Emergency Medicine Group at the University of Toronto, and is the founder and strategic co-director for the Toronto-Addis Ababa Academic Collaboration in Emergency Medicine. I'll just get Dr. Landis to say hello.
Good morning, everyone. Thanks very much, Amanda. I believe I'm also supposed to say that I have no conflicts of interest at this time.
And then in addition to Dr. Landis, Dr. Kirsten Johnson, our current CAEP president, will also be joining us and speaking in the second part of the talk. Dr. Johnson is an associate professor of emergency medicine at McGill University in Montreal, Canada. She practices emergency medicine at McGill's University Health Centre Hospitals and the far north of Quebec in Nunavik. She is the current president, as we know, and she has just returned from participating in a response to COVID-19 in Lebanon and will tell us about her experiences there. You want to say hi?
Thank you very much, Amanda, and it's a real pleasure to be part of today's CAEP National Grand Rounds. I'm very excited, and I also want to say I have no conflict of interest. Thank you.
And just to complete the housekeeping from accreditations, the Scientific Planning Committee has reviewed the Declaration of Conflicts of Interest, and no conflicts, perceived or real, have been identified, and there has been no external support received for this webinar. Similarly, I have no financial disclosures. The last housekeeping detail is just to post our objectives, and our objectives today are to discuss with the group the development of the field of emergency medicine at the international level, specifically in resource-limited settings. We want to introduce the role of the WHO in emergency care development through their Global Emergency and Trauma Care Program, and then understand some of the positive and negative impacts of the recent COVID-19 pandemic that has had on emergency care in these resource-limited settings. So our first speaker, Dr. Priyanka Railan, is an emergency physician and medical epidemiologist who coordinates the Global Emergency and Trauma Care Initiative in the Clinical Services and Systems Unit at the World Health Organization headquarters in Geneva, Switzerland. In the global COVID-19 response, Dr. Railan also leads WHO clinical COVID-19 training endeavors and supports efforts in clinical research. She's previously served as an Epidemic Intelligence Service Officer at the United States Centers for Disease Control and Prevention in Atlanta, and has worked in the clinical and epidemiology responses to several global outbreaks, including cholera, Ebola, diphtheria, typhoid, and others. She has spent over 10 years in various global emergency care projects and is trained in outbreak epidemiology, tropical medicine, and tropical ultrasound. And so as things happen in global emergency medicine, Dr. Railan was deployed to East Africa just a few days before we had planned these rounds today. She very kindly agreed to pre-record her talk with us about 24 hours before she actually deployed and flew out, and also on her American Thanksgiving. So we really want to thank her for still being able to join us and connect. We expected she wouldn't be able to connect to join us live today, but we're so happy that she was still able to give her presentation. We will still take questions for her, and if we are not able to answer them live this morning, we'll do a Q&A with Dr. Railan that we will post after the talk, after we can connect with her again. So without further ado, we will jump into her presentation. So I want to thank you so much, Dr. Raylan, for joining us tonight and for speaking to all of the physicians in CAEP for our grand rounds on December 2nd. We're going to jump right in, and we're just very excited to hear you talk about your emergency care and also your response to COVID through the WHO. So I'll let you get started.
Thank you so much, Amanda, for that introduction, and thank you for having me here and making these accommodations so you allowing me to speak. And I'm sorry I can't be with you tonight, at least so far. But looking forward to maybe meeting some of you in person someday. But I wanted to just start off by saying that emergency medicine as a field in North America, which is also where I'm from, is quite a different. It's quite a different beast in North America as it is in many parts of the world. And there's many different ways that we can get involved in global health and look at global emergency care, which is what I'll talk about today from the perspective of WHO. And it'll be really exciting for me to hear more about the work that CAEP is doing and what you all are interested in terms of the global work from emergency care. So I'll give you the perspective of WHO and sort of how we've been working on emergency care in a couple of different ways. And then, of course, happy to hear about more endeavors on your end as well. Just for the sake of this talk, I have no disclosures. And so I'll start off with just saying, I think a lot of you are familiar with this type of emergency medicine, emergency care in some of these hospitals, maybe even exactly these hospitals. I chose these just because of my personal connections to Canada. I have family and friends in various parts, and I think we're all quite familiar with what emergency medicine looks like in these walls. But what we do here at WHO, we're in a very different mindset here. We're thinking about emergency care and emergency medicine in different contexts, and what does it really look like to be able to provide emergency care in these types of settings. These pictures, save for the one on the right, are all from the time of COVID. So, talking about when we talk about all the different things in the COVID world, in terms of caring for patients from the time that they may feel sick to the time they have to get tested, and maybe they need to see somebody acutely, maybe they don't. But all of the different steps of the pathway of a patient accessing healthcare in the time of COVID really has seen so many different facets because it's affected so many people globally in all different countries and all different contexts. And so here at headquarters in WHO, the way we think about emergency care and COVID and every other disease and every other topic area is really looking at all of these different types of contexts, including places like Quebec or Vancouver or Toronto or Ottawa, but also all of these other places. So what we know is that emergencies occur everywhere, and no matter where they happen, they're going to be people that have to access emergency care, and they're going to consume resources regardless of whether there's somebody there or some system there that's capable of achieving a good outcome. And so the way that we here in Geneva and working at WHO as the UN Health Agency, we work together with all the other health agencies of the United Nations. WHO is obviously the leading one, but there's also the UNICEF, the United Nations Children's Fund, United Nations Population and Women's Fund, UNFPA, and several other UN agencies that also work on health and building health. And so we work together with them. And the way that the UN has looked at building good health and well-being is to the Sustainable Development Goals, which is some of you may be familiar with the Millennium Development Goals that were back in 2015. And so the SDGs are sort of the new era of that, and they represent a sort of social charter, a social contract of what the world wants to achieve in moving the world forward into better health and better well-being in a global sense. And so when at WHO, we focus a lot on SDG number 3, which is good health and well-being. But what we know as emergency care specialists, that we also actually have a huge effect on society as a whole, being at the front line. And so SDG number 11, which is about sustainable cities and communities, and SDG number 16, which is about peace, justice, and strong institutions, they also have these targets associated with them that emergency care has a stake in, because we see patients that are affected by disasters, and we see patients who are affected by violence. And you know, it really allows this to be a way for us to advocate for why emergency care is such an important piece of SDG number 3, or a really important piece of health and the work at WHO. So just really quickly, I'm going to talk about how WHO is structured and how we work, what we do, because I think a lot of the way that we've been working on emergency care for the last several years has been from headquarters perspective, sort of in this big picture sense. So WHO, as the main UN health agency, we have a vision of these three triple billions that are the triple billion targets that we talk about in terms of how we look to have people who achieve universal health coverage. And I'm going to talk a little bit more about that. Our Constitution talks about health being the fundamental right of every human being. And sort of this is how our big picture is structured. And we work here at headquarters in Geneva. There's also 6 regional offices that we work through, providing support to about 150 country offices around the world, who then work together with ministries hand in hand and help deliver implement the policies and the projects that come together. And so our whole big structure here at headquarters looks a little bit like there's lots of arrows, lots of boxes, but essentially what it comes down to is sort of health systems and the Health Emergencies Program, which is a new program developed in 2014 after the Ebola outbreak that looks at outbreaks and disasters and those types of things. So I'm going to talk a little bit about both today, because emergency care is, as we just said, sort of at the forefront of both. And so, in terms of health systems, what we talk about is like universal health coverage, and what we look to achieve is universal health coverage for at least 1 billion people. And that is what we mean by universal health coverage are these 3 key aspects. What we want is for an equity and access to health services across the world, so that everyone who needs services should be able to get them, not just people who can pay for them. That the quality that the health service that a person receives at that front door is good enough to be able to improve their health, and that when they receive that health service, that they are protected against any financial harm that could be potentially done by that. So this is the crux of our work, and defining what these services are is a big piece of work, because there's a lot of context, as I mentioned, that we need to consider, and of course, all of the things that come along with that. So we take our mandate from these big meetings that we have every year in May in Geneva, except for 2020, because that's an anomaly. We have about 194 health ministers that come from every country around the world and sit together and decide what they would like the WHO to be able to assist them with in terms of reaching these targets. And so the way that they do that is the health ministers will come together and write these resolutions. Resolutions are documents that list out key components, key issues, and at the end, there's a couple of different sections. One section is about what does the country need to do, and the next section is about what does WHO need to do about that issue. So over the last several years, you see here in 2006, but carrying forward, there's been many different resolutions that have to do with emergency care. And then in 2019, just last year, we had a brand new resolution on emergency care systems that really got to the crux of this timely care for the acutely ill and injured. And this was brought to the floor by Ethiopia and Eswatini. And there were about 34 countries that spoke from the floor in support of this resolution, and it was passed unanimously by all 194 health ministers. So it was a really big feat achieved for the world in terms of setting the stage of what emergency care is and how it's an absolute essential part of universal health coverage and delivering universal health coverage to the world. So Canada included was an advocate for this resolution, which was really great to see. And so what it lays out is really how countries should be able to build up their health systems. What does it even mean to have an emergency care system? And the way that WHO, the way that we've defined it, the way that this is an infographic, and of course there's a lot of text behind this as well that's available online. But we try to show countries and policymakers and getting people to understand what we mean by emergency care. Emergency care is such a new field in the world, and it's only really kind of well developed in the North America and some parts of the Pacific and some parts of Europe, but in the rest of the world, and even in some of those parts, it's done in different ways. And so this sort of helps to define the different functions of emergency care. And you see here in blue, the human resources in red, and the equipment, the supplies, the information technologies, all that in green. And it helps to put all those pieces together. And so when we show these things to countries and to ministries, we help them assess each part of this emergency care system through sort of a national assessment that I'll talk a little bit more about, and I can even dive deeper into. And what we've learned after doing these assessments in about 40 countries now is a lot of these countries have the same sort of gaps across the board. So, no universal access number or total country coverage. So that's like a 911 or a 112. There's no system-wide or centrally coordinated dispatch for free hospital care. There's gaps in training and certification for ambulance providers, limited emergency care core staff, triage that doesn't happen formally. So there's a lot of these. Each part of this framework has been assessed like I said, about 40 countries. And what we found is a lot of these gaps are the same. And so what we've done over the last several years is to build these tools to help fill these gaps. So if the country has identified that they don't have emergency care training, we have built this emergency care training manual with the ICRC and the International Federation for Emergency Medicine, of which CAEP is a partner. Similarly with triage, if the countries have highlighted that they don't have a formal triage system, we've developed an interagency triage tool with ICRC and MSF and IFRC, again, taking into the different contexts that these different organizations provide. These are just a few of the tools. We have about 20 or so, and you can go to the website at the bottom there, who.int/emergency care, to see some more of them as well. And so that's what we've been doing over the last several years, working with countries, figuring out what their gaps are, and then helping them fill them in with all these different tools. And if they don't have a tool, we work with our partners and with our global experts to be able to make a new one. And so this is just a couple of pictures and tweets actually from our Director General, Dr. Tedros, about emergency care, really highlighting the importance of it as being at the front line for the rest of the world. And in the right tweet, he mentions this initiative, this Global Emergency and Trauma Care Initiative, which is something that I help with here at headquarters. And that's where the crux of our impetus and our ability to actually implement some of these tools, look at how they're being monitored, and how much impact they're having on the ground is done through this initiative. And I can talk more about that afterward as well. So just going back to this quote, because we talked a little bit about, we know that emergencies occur no matter what happens. There's always some kind of emergency going on. And sometimes it has to do with road traffic accidents and injuries, and pregnant ladies having emergencies and children with fever. But sometimes it ends up being a pneumonia with an unknown cause. And this is taking a step back and looking at sort of a global level emergency. And this is, of course, I'm referring to this call that we got back at late December 2019 that eventually led to what we've now known as the COVID pandemic. And what happened in terms of this emergency is we activated what's called the International Health Regulation. So now I'm getting into the other side of the house, the Health Emergencies Program, and sort of how we respond to these potentially these big emergencies with a capital E, if you will. And the International Health Regulations were stipulated in 2005. And it requires countries to be able to report to when there's an unusual or unexpected event that's going on, like when we got the call about pneumonia of unknown cause. And so there's a list of questions that have to get asked. And in order for these questions to be asked, to be answered in the emergency committee, then the highest level of concern can be declared by the World Health Organization, by a director. And that was what was done on January 30th. So there was a declaration of it's fake. And just to give some context, there's only been a handful of other fakes in history. So you can see we're in a very, very unusual time, just unprecedented times that we're living in. And this is what's brought together a lot of the global world and even internally here in WHO. What we learned from our previous Ebola outbreak on our previous fakes was that we didn't, when we developed this incident management structure, as many of you are aware, in terms of when there's a mass casualty or there's a mass response, the incident management structure will get activated. And what we learned from the previous outbreaks was that there wasn't a pillar within that incident management structure that was taking care of all of the other health services that need to continue during this massive outbreak. So from 2014, we learned that there were many, many, many more deaths from the fact that people could not access the same health service for their routine malaria medications, or their routine HIV medications, or their routine antenatal care, because the entire health system collapsed and they were only able to care for anyone with Ebola. And that's what everyone focused on. So the health workers were completely shifted over. And so with this fake, what we did very, very early on here at headquarters was build in a new pillar on what we end up calling the maintenance of essential health services, or basically the health systems pillar. And I put these two of this one with pillar 7 in red, because this is sort of both the way that emergency care fits in, right? It fits into the emergency response, to the outbreak response, because we're at the front line for that. And we're also at the front line for everything else. Anyone else who has any kind of other issue going on, we're still there. The doors are open. And so we've been able to work across these two pillars, in addition to building the health systems response to the outbreak. And so I'm just going to talk really, really quickly about what the different work streams are within each of these pillars for the COVID response. There's work that we do in the clinical management side about how to actually care for this brand new disease, right? We're learning constantly about new vaccines now, but also new therapeutics, and even just sort of the characterization of the disease. How long do people have symptoms? What kind of symptoms do they have? How sick are they getting? Does it look different? Are there different phenotypes according to the disease? So there's a lot of research, a lot of things going on, and we develop guidelines with our global experts through our rigorous process in terms of how to manage COVID-19 clinically. The graph at the bottom is a tool that we had developed very early on to help countries and facilities determine how to surge their staff members. I'm sure a lot of you had also felt different fluctuations in terms of your staffing. And how do you decide how many nurses do you need on a given ward, or how many doctors you need? And if you don't have that capacity, how can you task shift or task share across different cadres of providers in order to build up their capacity very rapidly? So we worked on developing these surge tools, and we've been working with the World Food Program and across the different UN agencies to build this new global supply chain system. And that has been a large endeavor, harnessing really all of the power of World Food Program and their massive planes, and the procurement streams and supply chain streams of these other large UN agencies in order to deliver PPE and clinical supplies, including ventilators and oxygen, really building up oxygen capacity as well, and of course training. And here I show the basic emergency care again, because again, basic emergency care is at the front line. We don't know if your difficulty breathing is because you have COPD or because you have COVID. And so it's the same approach that we take to anyone who has any kind of chief complaint. So it's a syndromic approach. So it is very much relevant here. We're working on understanding the clinical characterization of COVID, as I mentioned, and so we have a new COVID clinical platform that sort of helps us gather all the data from global across the world and put it together in order to help us inform what different areas of the world are seeing in terms of their COVID response. We've had to work on new innovations as well. COVID has shown us that the way that we think about the world, the way that we think about health systems, even in well-developed areas, really needs some new structure and restructuring. So there's lots of different, this is a schematic of colleagues working in Italy in terms of how they've had to rethink about how to restructure new hospitals in the future. And of course, we've had to work together to build up the oxygen capacity. This has been a long-standing issue for many years, how to scale up oxygen systems. And this is a busy slide, but it's just to show the complexity of what it means to have oxygen in these scarce resource areas. And it really requires a multidisciplinary approach with biomedical engineers, clinical engineers. So I've been learning so much about, as an emergency care provider, all the different things all the different pieces that go into an oxygen system, and how can we get that done in a place that has never seen oxygen before, and how that can help not just COVID, but of course it can help with so many other things. And going along with the different devices and the different types of oxygen delivery systems, we have to of course train people not only on the use of it. So step 3 here, as you see, the clinical use or the patient care, but all the different steps that go into a device. To be able to make sure that this is done in a sustainable way, all of these interventions. There's been so much that's been brought to the spotlight because of COVID that all has to link into emergency care systems. Our health systems and services pillar has been really helping at countries from a more policy level, a little bit higher level, understanding what are the different health services that they can provide, and how to decide, when to shut down an immunization program or when not to, which ones to, how to define those essential services that need to continue while the outbreak response is ramping up. So immunization is one example, of course, antenatal care, malaria care, etc. So we've been working with countries on defining these services and helping them deliver the essential health services as well. And all of this put together into this new COVID pathway, where we've shown sort of the different elements of what we do, and especially in emergency care at the front line. When a patient walks through the doors, we have to be able to screen them to apply the right IPC. As soon as we have a suspect case, we need to be able to make sure that it's done safely. The triage and assessment of that patient is done safely. And these are really broad concepts, but they're really challenging to be able to implement in some of these places that haven't thought about this before, they haven't had a screening area or a triage area before. They don't know what those words mean, and how to operationalize them, given they live in those types of settings that I showed you in the first couple of slides. So helping them visualize this in their way, and then sort of putting in our tools where we already have them from the health system side, and then being able to help them apply them in these different context areas has been the crux of the work. And then putting that together with this global emergency and trauma care initiative, which I'll talk about more maybe, which is our way of sort of implementing these tools, has been being able to bring together the emergency care systems and the COVID work, and sort of leveraging the spotlight that emergency care has on the world right now because of COVID, and using it in a sustainable way, and being able to bring it to the ground. So I'll stop there because it's already been a little while, but happy to talk to Amanda more maybe, and hopefully talk to you all also as well.
Thank you so much for that, Dr. Raylan. That was fantastic. I really loved the overview and how you piece that all together, and the using what you're already doing in emergency care and then leverage that into COVID is great. So there's a couple of questions that I had that came up through. One, kind of even prior to COVID, are there certain things that you think that have been, and I know you spoke about challenges and those sorts of things, but on the flip side, are there certain strengths or particular opportunities in a low resource setting that they've really been able to use to start developing their emergency care?
Yeah, absolutely. That's a great question. I think it's really bringing it to the attention of the policymakers and the people who have the will and the buy-in, in the country. And the way that we've been able to do that, and one of the strengths that people don't even realize that they have, is that they wear many hats in these countries where there's low resources and people are just doing many jobs all at once. And so what we find is that sometimes in country offices or in the ministries, that there's one focal point for maternal health, and they also happen to do HIV care, for example, or they also happen to do a group of other things. And what we can bring to them is emergency care as a concept that can actually help you with all these different things. And they don't even realize that they have that strength. They have this perspective of all these different diseases and these different areas, and they see them as sort of different areas, like silos almost. And in a lot of ways in the chronic world, and maybe they are, but when it comes to the acute conditions and the acute manifestations of a pregnant lady having her issues, or a child having his or her acute issue, or acute manifestation of an HIV crisis, for example, it's still the same provider at the front line who will be dealing with all of those different things. And that's the strength of what we bring as emergency care physicians, and a little bit of a lot of diseases, a little bit of a lot of different areas of work, and that's what we try to show them also that they have within them already. And that's been a really great leveraging power for them to be able to use emergency care as a vehicle for them to do so many different things all at once within their portfolio. And so they really harp onto that. That's been a big win.
And similarly, have you seen positives that have almost come from that spotlight of emergency care having to take care of COVID? Have there been kind of crossovers because there's been this attention that has maybe we can then use to improve emergency care in general? So things like funding, or that maybe they wouldn't have initially got an X-ray machine, but because they need to then look for COVID. Have you seen things like that coming up in lower resource settings?
Yeah, absolutely. Actually, it's been really fascinating and amazing to hear from so many different parts of the world. I had a call with call Palestine one day, and I have a call with Nepal another day, and have another call with some other country and a regional level. And they're all saying the same things. They're saying we all have this great momentum right now to be able to build our systems, like because everyone wants to do something about COVID. And so, we're just starting to build this pre-hospital system because they realize, no one can travel. They don't want people to go out and about in the street. So they'll have this telephone number, this teletriage that they're trying to set up. And so what they've done is they've basically set up a dispatch center, and they set up this one number that everyone can call to check in to see if they have an emergency condition, should they go to the hospital, should they not. And it's they're setting the basics of the foundation of their pre-hospital care system, and they don't even realize it because they don't have that before. We've already identified that as a gap in several years ago when we did their national assessment, and that's been a priority, and that's what they've wanted to do. But it's taken so much discussion and getting all the right buy-in from all the different folks to be able to build a number. What should the number be? And there's all these different things that take a long time, but now that we really, really need it, because we need something for COVID, it's all the spotlight has come together, and they've been able to really build a foundation. And now we can help them use that foundation, leverage that, and really expand it and make it long lasting, and help them figure out a way to do that. So it's really accelerated so much of the progress that they had already started. That's
fantastic. And I think the other one that I expect you've seen, and particularly with your epidemiology background and outbreak background, a lot of countries, perhaps better than North America even, are already set up for outbreaks and already set up for some screening if they've already, say, been through things like Ebola or been through things where they really have had screening. And so I wonder if there's some cases where they were able to just use, there's lots of mechanisms already in place that just shifted to COVID.
Yeah, that's something that we saw very early on in DRC. For example, DRC was having an Ebola outbreak just at the beginning of the year that sort of ended, and then COVID came, and then another Ebola outbreak came after that. And DRC is an example of a country that's just sees outbreak after outbreak after outbreak. And so they certainly have a lot of mechanisms in place, for example, and other countries as well who have seen multiple different outbreaks in a very short time, unfortunately. And yeah, they were able to this again, the same providers shift their mechanisms in such a way that it's a different IPC, so it's a different outbreak, right? So they have a different flow that they need to do with their patients and at the front door. But at the same time, it's really highlighted the lack of the underlying system that, because they're constantly dealing with outbreaks, they haven't been able to build that foundation to really spend the time that it takes and put in the resources to build the system, because they're just fighting that. So it's been a little bit of both. They have a lot of strengths in that regard, but they're also looking to move things forward with as much as they can to build these systems in place and to have the trainings, to have the pre-hospital numbers, to have all the triage facilities within a health facility, which have the different systems in place within the health facility to be able to direct patients appropriately and things like that. So they've that's been one example, but there's been many countries like that have recognized that they need to focus more on the systems, and even to sort of going back to places like Italy or Spain or Germany, where they had a pretty well functioning system, and they don't see a lot of major outbreaks, but they also realize, well, we hadn't actually prepared as well as we thought we did, right? That hits so hard, and so they think that they're doing well, they're doing okay, but then something like this happens, and they realize there was a lot more to be done to prepare. So it's really shown that emergency care happens everywhere all the time. It doesn't matter what kind of health system you have a lot of work to do to prepare for anything.
Yeah, fair enough. In that, the infographic that you had, so through the trauma care initiative, when you look at, particularly in, say, a very low resource setting, that excellent kind of comparison between the emergency rooms that we're used to and a place that is just getting started with primary care and very low resources. When you do that assessment and you find those gaps, and using that, and you see, say there's gaps in many different parts of the system, what's that kind of approach you take there to not overwhelm and decide which of the gaps you're going to try and address, and what's feasible now and how much to do?
Yeah, that's always a challenge, because these things involve a lot of different stakeholders in a country, and so there's a lot of people to bring to the table, a lot of discussions and understanding what the priorities are, and so that it's a process that we facilitate for the ministry. The Ministry of Health usually is the one who convenes all the different stakeholders in that assessment process. And then they bring those stakeholders together for a meeting in which we talk about each of the different functions. We literally go question by question and talk through, is this a priority for you? Is this not? And what do you all think about it? So a lot of times within one country, the stakeholders don't necessarily realize that it's different in a different part of the same country. They think this is how it is. And so it's really just getting people from all the different parts of the country to the same meeting room, or in this case, virtually, and just having them talk about it amongst themselves, and we facilitate. And then at the end of that, the ministry will then work with the stakeholders in terms of defining what kind of, what's the top priorities, maybe the top 10 or the top 20 or the top 30, and sort of ranking them and deciding which ones are we going to do when, and how much is it going to cost, and what kind of impact is it going to have. So we sort of help them with that process. Like, we help them figure out what to do, how to do it, but we don't necessarily tell them what to do. I mean, that's up to them to decide within the country. And so, yeah, it's really in their hands. And a lot of times, especially in emergency care, as you mentioned, it's cross-cutting, right? We see a lot of primary care, if you want to call it that, and surgical care, critical care. We sort of see everything. And similarly, sort of in the policy side, it's not just Ministry of Health that we have to also bring to the table. We have to bring the Ministry of Education, the Ministry of Transport, information technologies. There's a lot of different elements, because we want to build in a strong system at the foundation. And so that means, if we have like a 911 or 112 number, we have to bring in all the telecommunications agencies. There's so much more that goes into building a huge system like this. That's not just the clinical aspect. And so the Ministry of Health will say, well, I have to talk to the Ministry of Education colleagues about how to integrate a basic emergency care course in terms of accreditation, certification, the long-term, so those things take a lot of time, but we just help them figure out what works for them, and then they sort of take it from there.
Great. And it sounds like that does help grow it at the national level, as opposed to things happening in silos in kind of several different cities or each different area of the country doing it differently, if you can bring that all together and kind of coordinate it.
Exactly. That's how we try to. I mean, a lot of sometimes, especially in conflict settings and these fragile states where they don't have that capacity to be able to bring people together. It's not feasible for them. We do things in like a sub-regional way, but it really, really preferably is to take it nationally. That's the vast majority of how we've done this work, where we're really here to support them and whatever makes sense for them.
Gotcha. Okay.
Yeah.
And have you seen any like once one country or one area of a region has developed or grown, has there been ways to then leverage that to then coordinate with the next country or the larger region, and then kind of use that expertise and share it among the closer partners, as opposed to kind of collaborating with North America and someone that's a kind of a totally different system?
Yeah, that's always preferred. That's really because people within the same region, they have a lot of similarities and they can learn a lot of lessons amongst themselves, and so that's worked really well, especially in the training aspect, because there are a lot of providers who are working in similar types of contexts, and they either have a health post maybe or health clinics, and they can just sort of share lessons learned across different countries. And what's worked really well in like the Asian region and the African region is when we have these regional level trainings. If a lot of countries have identified that like they don't have training or they don't have triage, we can bring them together in a regional way, and then there can be providers that are trained all at once in these WHO tools, and then they can go back to their respective countries and then train them. So we do sort of a cascading training of trainers, and that's worked really, really well to bring a few people together from different countries, and then they sort of like make their own WhatsApp groups and then stay in touch and you get to sort of see that blossom across the region, and that's been really exciting. Yeah.
Great. All right. Last question, just in terms of CAEP and Canadian physicians. I wondered if you had some insight or ideas in terms of, I know we have tons of members who are engaged in many, many global projects, but thoughts along the way of anyone listening right now of like simple ways that people can get involved or ideas, and then particularly, again, COVID related, if there are, say, virtual opportunities that are new or have come up that may be ways that without traveling people could still start to play a role.
Yeah, absolutely. It's so great to have the support of organizations like CAEP in the work that we're trying to do. We're all in it together. Right? This is trying times, but we're all looking to help countries around the world build their systems and be able to respond safely and effectively to this disease. And I think, speaking with Dr. Johnson's been amazing to be able to work with. And so she's got some really strong ideas as well, and ways that we're looking to work together in a global way, and we'll continue to work together. But specifically for those colleagues who maybe know about projects already or know about countries that different institutions have already had relationships with, or if you're looking to maybe start a new relationship with a new country or a new institution, I think the best thing to do is sort of think about engaging with the rest of the countries and the rest of the networks in that area, in that particular region, or even within that country, or even that sub-region within a country, and sort of think about doing something in a more coordinated approach that can help amplify the work that you're doing and that others are doing. And it takes a lot, it takes more of sort of that discussion. It's more listening actually than it is talking.
Yeah.
Listening to the needs and listening about their experiences and trying to understand, their day-to-day is really, really different than our day-to-day. And it comes down to much more than just the patient provider sort of interactions. Has so much to do with the devices, the supply chain, what are they used to, and what can they sustain in a long-term way. And so I think, seeing what works for you in terms of where you would like to make the biggest impact in terms of what part of the world, and then sort of listening to that part of the world and seeing what's important to them and how you can feed into that bigger perspective and that bigger narrative. And certainly, at headquarters, like I mentioned, we work through our regional offices and our country offices. And so if there's certain areas of the world, or parts of the world or partners even that you're already working with in certain countries. I think it's a really great idea to get in touch with the WHO country office in that particular country, and then sort of see how they've been working with the colleagues on the ground and building their systems, and telling them about these tools if they don't already know. I mean, we work in a lot of countries. We support them. We support everyone that we possibly can, but we haven't reached all 194 for sure. So there may be many others that don't even know about these things. So feel free to share these tools, and we can share lessons across the different regions and the different countries. So let us know. We'll be happy to help support that, build that network as well.
That's fantastic. So thank you so much for your time. I'm so excited and so glad that you were able to join us. We will keep our fingers crossed that you will also be joining us on the live day after this recording. But in case you can't, I really want to thank you for taking the time, and hopefully we'll speak to you again soon.
Thank you so much for having me. It's been a pleasure, and yeah, stay safe, everyone out there, and thank you for being at the front line.
Thanks. Maybe what we'll do now, Megan, we haven't had any questions that have come through yet, have we?
I don't see any yet, so we can.
You know what?
Let's start with, yeah.
A second. You know, it's interesting watching Priyanka's talk, and certainly actually I've been in touch with Priyanka while I was in Lebanon, because I was applying these tools that she's kind of introducing and what we're just kind of in the middle of. So maybe I'll just give a little bit of a backstory here so that people know what we're talking about, and then I can reflect on how useful these tools are in terms of applying them in real time. And so my name's Kirsten Johnson, and part of my work in emergency medicine has always involved global EM. And so I had I was fortunate enough to be invited to go on an emergency medical team mission as part of UK Med, so under the British government, funded by FCDO, which is now their new name for DFID. And we responded just after the blast in Beirut, in Lebanon, that happened around August 4th. In fact, the team flew in to do an assessment to see if there were needs immediately after the blast, but it turned out there was more of a need for COVID response. And so we were kind of reappropriated to that, and we were working under the umbrella of the World Health Organization. And so I was in touch with Priyanka in that regard. So just a tiny bit of background on Lebanon, and then I'll segue into what I was doing there with the EMT, is that for those of you who don't know, Lebanon is a beautiful country in the Middle East, and it was they used to be called the Paris of the Middle East, because I understand that it was quite thriving and had a lot of great nightlife and a beautiful location and so forth. But unfortunately, over the last year and a half, the economy has collapsed due to the fragmented government, and there's been a revolution and against this, corruption that's very well known and so forth. And so now the lira has fallen, and so you can, bread used to be about $1, which is 1,500 lira. And now a dollar is about 10,000 lira. So it just means that people can't afford to buy food. There's abject poverty. Lebanon is host to the world's largest population of refugees, both from Syria and Palestine still. And then, of course, the Beirut blast hit after years of civil war. So when you go downtown Beirut, many of the buildings are empty, bombed out. It's hard to know if it's from the blast or from war. And there's not much, rebuilding going on because there's no economy to do so. A lot of people who have been able to have already left. And we're a host to a large population of Lebanese immigrants in Canada. Then now COVID. And so it's been a very difficult time for the country. And unfortunately, it's certainly not the Paris of the Middle East anymore. And the government asked for assistance from the World Health Organization and from other organizations to help with things like housing, shelter, food, and so forth. So part of what Priyanka was talking about certainly was the Health Emergencies Program. WHO has different programs. It's one big umbrella organization, but there's many different kind of programs that operate underneath it. And part of the health emergencies program is the World Health Organization Emergency Medical Teams Initiative. So the EMT initiative came to be after Haiti in 2010, when the world saw the largest volume of responders ever to a natural disaster. And so we saw maybe over 3,000 organizations being involved in the Haiti post-earthquake response. But unfortunately, many of those were university hospitals wanting to send teams of medical personnel down to help. But many of those had no training in the humanitarian space, and many of those people, it was their first mission. And so they really didn't know what to do. And we saw, horrific sort of outcomes of that response, field amputations being done by resident physicians who had no experience doing amputations, with very poor, hospital infrastructure and so forth. And after that, the World Health Organization, together with the Interagency Standing Committee of the UN, came together and said that medical missions had to have proper vetted personnel and be self-supporting and so forth. And so the EMT initiative was born.
So maybe tell us about how you did use those WHO tools while you were there.
Sure. So part of my role with the emergency medical team was that I was the medical lead. So I was the only doctor. The team consisted of other medical specialists like ICU nurses. We had IPC control, so that's infection prevention control. And we had a logistician and a security person, communications, and so forth. So we worked together as a team to provide capacity, to build capacity for COVID response in 4 different public hospitals throughout Lebanon. The Lebanese system is about 80% private and 20% public. And the public hospitals were the ones that were kind of saddled with the majority of the COVID cases, because the private hospitals at the beginning didn't want to take them. There's a lot of stigma, and they would shut down operations and so forth. So, but the problem with the private hospitals is that they really had, as you could see from Priyanka's talk, it's a perfect example of the limited knowledge and infrastructure to be able to respond to COVID. Everybody knows from now working in COVID that, you can't put non-COVID patients with COVID patients. You have to set up a whole new flow for the emergency department and for the rest of the hospital. And even, rejig the intensive care units and so forth. And in many of these public hospitals, they didn't even have intensive care units. So my job was to go in to these hospitals and work with hospital administration, and then also directly with the doctors to help them set up their hospital systems, from pre-hospital to, admission to transfer of care if the patients became too heavy. And interestingly, 2 of the hospitals that I was working in didn't even have emergency departments yet. So it was interesting for me to really have a carte blanche and to work on how to set these up. And so I called Priyanka actually, and because I knew about the World Health Organization working to set up emergency systems in other countries, because Amanda, you're aware, and Megan, we've been talking with them about providing advisors from CAEP to work in partnership with some of these in some of these settings. And so I called her up and I said, I need a triage tool for these new emergency departments, and also anything you have on IPC training and on flow of patients and so forth. And so right away, she was able to send me the information that I needed in different languages in the form of PDF slides that I could use for training and other resources. So it was really cool that, I kind of was able to apply this very higher level process that WHO has been putting in place on the ground in Lebanon. And so I used those tools and created others. And WHO, of course, has a wealth of resources now for COVID. If you go on their online platform, you can find those. And so, I used the WHO resources to create standard operating procedures that were contextualized to the Lebanese context, and went from there.
Great. And that's actually one of my follow-up questions was, in terms of taking the tools, then what did you find needed to be adjusted or adapted to kind of fit the setting and changed?
Well, as you've mentioned, we were working in a low resource setting. So even though, Lebanon, you wouldn't think of it being low resource, the public hospitals are very under resourced. And so WHO, for example, when even for the clinical care of COVID patients, when there's guidelines for intubation, rock uranium is used for a neuromuscular blockade as a standard of care. But in some of these hospitals, they didn't have that. In fact, because of the economic crisis, there was just no hard currency to buy medications. And so there was massive shortages. So we had to sort of think around what we could use. We used cisaticurium and different kind of paralytic agents for conscious sedation, intubation. So that's just an example, but it's not useful to create a standard operating procedure that you give to the hospital to use if they don't have those resources. They don't, for example, either have non-invasive ventilation, the nasal cannulas like Optiflow. They don't have that, even though it's a recommendation. So we use BiPAP and so forth. So just specific tweaking for each of the hospital sites.
Okay. Dr. Landis, any questions that you wanted to add?
Not for Kirsten specifically. I am monitoring the chat group, however. So when you want me to jump in with those, then I'm happy to do that.
Okay. I think we can do that because I'm mindful of the time. So if you have questions from the chat, we should bring those up.
So I'm reading off my phone, many forms of technology at the same time here. So the first comment is actually both comments are from Don Milady from Mount Sinai Hospital here in Toronto. Hi, Don. I can't see you, but thank you for your comments. His first was, I'm overwhelmed by the complexity of these challenges. It makes my daily ED shift with one patient at a time seem pretty easy. And I do think that that's a well-informed opinion because Don has spent quite a bit of time teaching with us in Ethiopia in terms of capacity building at Black Lion Hospital over the years. So thank you for that comment. And he also makes the point that he's the new chair of the IFEM Clinical Practice Committee, which brings together people active in various subspecialty areas of emergency medicine. So if there is interest in engaging at an international level in building knowledge and guidelines, I think that would be a really nice way for Canadians to reach out to contribute some of their expertise. So I would encourage you to get in touch with Don, and perhaps you can get in touch with the organizers of this rounds to get his email as well. So far, that's it from the questions from the chat group. Maybe this question actually would be, we had received one question from the Twitter announcement initially, and I sort of would maybe direct this towards Kirsten with your experience in Beirut as well. But the question, and I'll paraphrase a little bit, but it was hoping that we could talk a little bit about the degradation of services when resources are scarce. Commenting that for those of us in disaster medicine, we're aware of the concept, would love to hear of the perspective. For instance, when hospital treatment capacity is reached for staff and equipment, what are some of the innovative or non-traditional ways that you can use to adjust your practice when these resources are scarce? I think it's a timely question because I think for many practitioners who work in low resource settings, we collectively have had to think through how do we navigate some of the things that you were talking about, Kirsten. I think the interesting thing that has happened for many of us around COVID is that we have had to have those mental acrobatics here as well in Canada when predicting what might be coming with this pandemic. So maybe you could speak to a little bit to that in Beirut around some of the creativity.
I mean, just to, off your point, Megan, I think a really one that touches us here in Canada is human resources. So we experienced huge human resource shortages in Beirut. And at one point, we had one intensive care unit with 12 beds and 2 nurses and 1 doctor. And in the north, Lebanon, I won't say where, but one hospital had an ICU of over 20 beds and one doctor who would come in 1 hour or 2 hours a week. So, I mean, it's certainly here in Canada, we're talking about rural areas. If they get overwhelmed with patients, they'll have a shortage. So I think that this is time that we need to look at disruptive kind of solutions, and how can we do something like federal licensing of physicians during times of pandemic. The WHO came up with an interesting solution for the nursing shortage in Beirut, and basically they trained up a bunch of nurses. There was, I think, over 260 of them that they deployed to work in the public hospitals, and that they paid directly because there were issues with paying staff and nurses were quitting and so forth. So that was interesting. And then also WHO came up with an interesting idea that was called the Twinning Project. And I think it's just getting started now, but they were pairing a hospital that was private with one that was public to help them secure additional resources, not only in terms of staffing, but in terms of supplies and equipment and so forth, and a referral system that was a bit more robust. So, I mean, it's like anything, and that's what makes it so interesting when you work in these settings, is that you kind of have to be creative and find creative solutions to these problems, because you can't just not find a solution. I mean, if you're there and your job is to provide assistance, then you need to think outside the box. And I think that that's what we need to do in Canada. My background being global EM, I'm very keen to see about how we could create partnerships with the Canadian Red Cross or other organizations that are already working with the federal government to create, find solutions in terms of staffing and deployment of teams and so forth within our own country. So I think that we need to get creative, and I think it's a good time to sort of start that discussion. And Megan, I'm sure you have points to bring up, and Amanda as well.
Well, I think the issue around human resources is a really interesting one. And I think that we can look back to many other healthcare crises or pandemics. And it makes me think about the HIV pandemic in sub-Saharan Africa. And watching the creativity that's happened in those health systems as I've been working there, it's, especially around human resources, has really informed some of my ideas about what we could do in Canada. But, I've watched systems do a lot of task shifting, which is something that I don't think that we're good at in Canada, in terms of training lower cadres of healthcare workers to do fairly routine type healthcare. And I was involved in a project to train lay persons to actually triage people who were coming to the hospital. And there's very good evidence using some of the WHO training modules, actually, that show that you can actually, by training lay people, you can make them competent enough to triage, and you can reduce mortality. And that is measurable in many of these systems. So I think there's a lot of learning that we can do, especially from systems who've experienced stress and pandemics over time. And there's some creative solutions that I think that we should at least start to talk about in Canada, in a much more sort of rigid, traditional place that's less easily changed, but may need to look to some of these things.
Mm-hmm. For sure.
I completely agree. I was going to bring up the same, that a lot of the humanitarian situations I've worked in with community health workers carry a large amount of the medical piece, in terms of just being trained on a very focused idea like hand washing, like hygiene. And they're often people who are experiencing the humanitarian emergency themselves, but are trained to then teach their communities. And you don't necessarily need people that are fully trained as physicians and nurses to do a lot of those tasks, which can then free up your physicians and nurses to do the higher level things. And so I think, that's already being done and already been shown to be very realistic and very effective. And so I think that is something we could consider here as well for different ideas.
And just to interject, hello, Don again. He has another comment in the chat. He said that twinning project is not unlike our practice in using training high resource hospitals with low resource, low long-term care facilities. So some of that work is already, and that idea is happening within our system around COVID. Agreed.
Okay. Any last ideas, anything, Dr. Johnson, that you'd want to add before I close out? We are a little bit past 12 o'clock now.
Sure. I mean, I just to close, I think that just to update people in terms of what the CAEP Global Emergency Medicine Committee, your committee, is doing, which I mean we're all involved with. You know, I'm hoping that we've kind of sorry. We've pitched this. Well, Amanda, maybe you can jump in and talk a little bit about this idea of working with WHO and providing some advisors to help with the development of EM systems in these countries.
Yeah, I can mention, and you can jump back in as well. But I think we're looking at the idea of that WHO development, where they do pair kind of advisors to start to fill those gaps after they've done their evaluations, where they look that they have a kind of consultant team that will go in and help develop and address those gaps with all of the local organizations on the ground. And so with the CAEP Global EM Committee and Dr. Johnson and through WHO Connections, we're hoping to start to develop some partnerships there where we can, in areas where the WHO has already done their investigations and done their analysis, to then potentially be able to provide, if CAEP members are interested, to become parts of those teams that would work as consultants.
Yeah, thank you. And sorry about that, my little emergency there, the dog. But I just want to thank you, Amanda, for all your work on this, and Megan. And I am hoping that we can really highlight global EM in CAEP in the next couple of years. It's one of my, interests, and I think it's very important that CAEP makes a global footprint. And I think there's a lot of people doing great work in CAEP in global EM, and I think it's our time to shine. So thank you so much, and I look forward to working with everybody.
Great. And yes, feel free, everyone, to reach out to me as the Global EM Committee, or any of us anytime, to discuss this further. I really want to thank Dr. Landus, Dr. Johnson, and especially Dr. Raylan for managing to fit us in pre-departure to give that wonderful presentation. And thank you to everyone who has logged on and joined us. The last couple of housekeeping things: that there is an evaluation link in the chat if you're interested, and your attendance certificates will be sent out. And then coming up, our next grand rounds are on December 16th. Those will be trauma resuscitation, doing the best with what you've got. It will be case discussions with trauma experts in rural and urban centers. And that'll be featuring Dr. Bruce Moore, Sarah Giles, Chris Hicks, and Andrew Petronasiak, and hosted by Hazel Park. The rounds will be open to members and also to non-members for a fee, and that you can find more information on the CAEP website. I think that's all of my housekeeping details. Thank you to everyone. Thank you to our tech team for solving those issues so quickly in the background. They were doing tap dancing things in the background there. And thank you to everyone for joining.